Good afternoon. I'm Nancy Berliner, and I'm the moderator for the hematology section this afternoon, and I'm one of the course directors. You may recognize me since I snuck in to moderate questions when Ajay was giving his lecture this morning. And I'd like to start by introducing our first speaker, who is Dr. Maureen Achebe, who's an assistant professor of medicine in the hematology division at the Brigham, and is going to give a talk on anemia.
Thank you, Nancy. Good afternoon. I'm going to be spending the next 40 minutes on anemia, and I have a number of audience response questions that I hope you'll participate in. These are my disclosures. As you know, anemia is a hemoglobin or hematocrit below normal range for age and gender. Broadly speaking, anemia is either due to decreased red cell production, increased red cell destruction, or frank blood loss. And each of these scenarios is associated with a particular reticulocyte count. In evaluating anemia, we also pay attention to the size of the red cells and the peripheral smear. And in addition, an increased LDH, hyperbilirubinemia, that's indirect, and the absence of haptoglobin, when associated with an elevated reticulocyte count, indicates hemolysis. And when those are associated with a low reticulocyte count, it indicates ineffective erythropoiesis. We also look at RDW, and the RDW in a particular anemia gives us some insight into what the potential cause of the anemia is. Now, when we talk about the reticulocyte count, we're really interested in the corrected reticulocyte count, or the reticulocyte index. Now, the reticulocyte index is the reticulocyte count that's corrected for the degree of anemia. In a normal, healthy adult, the reticulocyte index is between 1 and 2. When we put together the reticulocyte index, which when high indicates either hemolysis or blood loss, and when low, associated with a particular MCV, in every case of anemia, our differential is pretty narrow. So it makes it easier for us to hone down on the cause of a particular anemia. Today, we're going to try to go swiftly through iron deficiency, anemia of inflammation, sideroblastic anemias, thalassemia, B12 and folate deficiency, and the hemolytic anemias. Now, the first case is a 58-year-old woman with lupus, hypertension, and GERD, who presents with intermittent headaches and fatigue. Her white cell count is 4.7, hemoglobin is 8, MCV is low at 74. Her platelet count is somewhat elevated. Her retic count is 1.5%. Serum iron is 45. TIBC is 520, which is high, and her ferritin is 20. Her soluble transfer receptor is 4.2, which is elevated. Her peripheral smear shows microcytic red cells, which means that the red cells are smaller than the nucleus of a mature lymphocyte. Which of the following would be of most benefit in this patient? An EPO-stimulating agent, better control of her lupus, 1 unit of packed RBCs, intravenous iron, or a proton pump inhibitor? Okay, so this patient has iron deficiency and would probably benefit most from intravenous iron. And we had a mix of responses, so we'll go over this. Iron deficiency is the most common cause of anemia, as you know. So the same lady, or similar lady, presents, same lupus, hypertension, and GERD. She presents 2 years later with fatigue, dyspnea on exertion. Her white count is 4.7, hemoglobin is 7.8. Her MCV is low, platelet count is normal, retic count 1.5%, serum iron is 19, TIBC 220, which is normal, and her ferritin is 209. Her soluble transferrin receptor is 0.9. What is the cause of her anemia now? So that patient had anemia of inflammation. And I'd like to point out the soluble transferrin receptor, which was normal and is only normal when you have isolated anemia of inflammation. But we'll go over these two. So the normal American diet contains about 10 to 20%, 20 milligrams of iron per day, of which we absorb 1 to 2 milligrams. We use 75% of that for erythropoiesis, 10 to 20% is stored as ferritin, and the rest is used in other processes, mostly enzymatic. And we lose about 1 to 2 milligrams in desquamation of the intestinal lumen and somewhat of the skin. Now, if we look more closely at absorption, you see that we don't absorb much, we don't lose much, and the homeostasis around iron in the body is really very strict. If we look specifically at the enterocyte, most of our dietary iron is in the ferric form. It's converted to the ferrous form to be absorbed through dimetyl transporter 1. Some portion of iron is stored in the enterocyte, but most of it transverses ferroportin to the serum. Now, hepcidin is a major regulator of iron absorption. Hepcidin works by blocking ferroportin when the body is iron sufficient. And hepcidin also blocks the extrusion of iron out of the reticulocytes, out of the reticuloendothelial system. So this iron that is then converted back to the ferric form is bound to transferrin and used for erythropoiesis, and there are negative and positive feedbacks that ensure that this circuit maintains erythropoiesis to prevent anemia. Anemia of inflammation is characterized by an inappropriately high serum hepcidin. During inflammation, macrophages release IL-6, and IL-6 causes the increased production of hepcidin. Hepcidin works in its normal fashion, so it blocks the extrusion of iron out of the reticuloendothelial system, and it blocks absorption of iron in the face of inflammation, whether or not there is iron-replete erythropoiesis going on. In addition, iron deficiency may exacerbate chronic diseases that have underlying inflammation. And there have been many studies in different inflammatory conditions showing that a compounding iron deficiency significantly impacts the clinical deterioration of a patient who has any one of these many inflammatory disorders. Now, back to the lab or in the clinic, the indices that we use to make a diagnosis of iron deficiency are serum iron, TIBC, the transferrin saturation, which is calculated from the two above, and the ferritin. And in iron deficiency, serum iron is low, TIBC high, and the ferritin is very low. In anemia of inflammation, the serum iron is also low, but the TIBC is low and the ferritin is either normal or high. So basically, when we're trying to differentiate one from the other, we're looking at the TIBC and the ferritin in a particular case. Now, this is easy if you have isolated cases of iron deficiency or anemia of inflammation, but often we find ourselves with combined combined states. Now, this is what led to the development of serum transferrin receptor. In a 1997 paper, 130 adults who were all anemic were subjected to bone marrow aspirated biopsies. A portion of these patients had chronic inflammatory processes that were known. Now, their results were plotted against the serum transferrin receptor that was found in each case. And I would summarize this by saying it's only in the patients who had isolated anemia of inflammation was the serum transferrin receptor really of any value, so that whenever the anemia was complicated by iron deficiency, the serum transferrin receptor could be normal, which would be below that line at 3, or would be abnormal. So it wasn't of much use. There were attempts made to make this the serum transferrin receptor more user-friendly in the clinic, but even converting it to a transferrin receptor ferritin index has not proved to be that useful, and therefore we don't really measure or test the serum transferrin receptor in our patients, although this is not uncommonly found in internal medicine boards. It's estimated that 2 billion people worldwide have iron deficiency anemia. First-line therapy is oral iron of really any formulation, but intravenous repletion has become more common, especially now that there are more intravenous formulations available that are safe. We expect reticulocytosis within a week of starting iron, whether it's oral or intravenous. There should be an increase in hemoglobin within 2 weeks, maybe not to normal, but at least an increase. And ferritin repletion may take up to 6 months. So that if you do not see these responses, it's important to look for a different cause of the anemia. I'm going to spend a little time on the intravenous formulations that are currently available. Low molecular and are FDA approved. Low molecular weight iron dextran was approved in 1991. There is a high molecular weight iron dextran approved in 1996, although we no longer use this. There are more recent formulations like ferric gluconate, iron sucrose, ferrimoxetol, and more recently, ferric carboxymaltose. Now, of these, the high molecular weight iron dextran is thought to be associated with the fatal anaphylactic reactions that are linked to iron infusions. Therefore, we do not give high molecular weight iron dextran. It is hardly on the market, and the ones that are on the market are safe. In our institution, we looked retrospectively at our use of intravenous irons, slightly over 600 patients over 2 years. There were 32 adverse events. There were no serious adverse events or anaphylactic type reactions. The AE rates were similar between low molecular weight iron dextran and ferric gluconate, slightly higher from using iron sucrose, but we concluded that all the IV iron formulations we use are acceptable, and we use these quite judiciously, but quite often, and with much benefit. Anemia of inflammation, as you would imagine, is the management is defined by identifying and treating the cause, but certainly that's not always that simple to do. ESAs are beneficial in patients, even patients with a normal creatinine. Intravenous iron increases the efficacy of ESAs. And the goal using EPO-stimulating agents is a hemoglobin of 10 to 12 and no higher. There are new therapeutic strategies being investigated that target the hepcidin ferroportin axis, but they are not in clinical use yet. The next case is a 40-year-old instructor at a firing range with no past medical history who presents with fatigue, irritability, dyspepsia, and arthralgias. Slightly hypertensive, pale, has some hearing loss, and peripheral neuropathy. White blood cell count is 6, hemoglobin is 9.3. He has an increased RBC protoporphyrin level, and his red blood cells show basophilic stippling. Which would you expect to see in this patient? Okay, I have very few people answering this question, and they're almost equal in the distribution. So I think this was somewhat confusing then. Well, you'd expect to see ring sideroblasts in this patient's bone marrow aspirate. Patient has lead toxicity, and it's marked, it's one of the sideroblastic anemias. So sideroblastic anemias are a heterogeneous group of anemias. They are not common. They are characterized by ineffective erythropoiesis. Now, the most common cause is myelodysplasia. So this would be an elderly person. Lead toxicity can also cause sideroblastic anemia. The use of isoniazid without B6 repletion. So this would be a patient with tuberculosis typically, and an alcohol intoxication. In a patient who has a sideroblastic anemia, the peripheral smear may show Pappenheimer bodies, which are free iron in the red blood cell, and the bone marrow aspirate shows these rings of extra mitochondrial iron around in a circular form in erythroid precursors. The next case is a 70-year-old woman with diabetes who was brought to her PCP by her family because of progressive dementia. Her labs are reported as normal. She started on Aricept. 6 months later, there's no improvement. Her gait is unstable. Her white count is 2.9, hemoglobin is 8.3, platelets are 85,000, and retic count is 0.9%. She's diagnosed with B12 deficiency. Her peripheral smear shows the hypersegmented neutrophils, and her bone marrow aspirate shows nuclear cytoplasmic asynchrony, which means that the nucleus is really much is immature compared to the cytoplasm. Which of the following would you expect to find in this patient? MMA is methylmalonic acid. So I have very few votes. I'm going to say the answer to this one is D. This patient has B12 deficiency, which is marked by an elevated methylmalonic acid and an elevated homocysteine. Patients with B12 deficiency may have a low normal B12 level. And we'll talk a little bit about that. So we absorb dietary fiber, folate as methyl tetrahydrofolate. 5-methyl tetrahydrofolate needs to be converted to tetrahydrofolate for use in DNA synthesis. And that conversion is dependent on the conversion of homocysteine to methionine, which uses or needs B12 as a cofactor of methionine synthase. Now, therefore, vitamin B12 deficiency begets folate deficiency. Now, adenosylcobalamin, so here, is a form of B12 that's a cofactor in lipid metabolism. So it's also a cofactor in the conversion of methylmalonic acid to succinyl-CoA. So that vitamin B12 deficiency is in vitamin B12 deficiency, there's hyperhomocystinemia as well as an elevated methylmalonic acid, while in folate deficiency, homocysteine is elevated and methylmalonic acid is normal. How we differentiate folic acid from B12 deficiency: the dietary history, B12 is only found in animal protein, so may be seen in increased frequency in patients who are vegan. Neurological deficits are restricted to vitamin B12 deficiency. The homocysteine is high in both, but methylmalonic acid is only high in patients with vitamin B12 deficiency. So when do we really need to check homocysteine and methylmalonic acid levels? When we have borderline vitamin B12 levels, we need to check those to confirm B12 deficiency. When both B12 and folate are low, we need to check both to distinguish a combined from an isolated folate deficiency. And when folate is borderline also, we need to check them to confirm folate deficiency. The next case is a 60-year-old woman with rheumatoid arthritis who presents with a 2-week history of worsening weakness and dizziness. Her white count is 4.7, hemoglobin 7.3, hematocrit 25%, MCV is normal, MCHC is elevated, platelet count is normal, total bili is high, retic count high, LDH high, her direct Coombs is positive for IgG and complement. Her peripheral smear shows spherocytes. What would you expect in this woman? Eosin 5 melamine to be abnormal, treatment with steroids to be beneficial, sputum culture to be positive for mycoplasma, osmotic fragility to be normal, or splenomegaly. Okay, great. I think this is, so we have more people answering this one. And the answer is B, and I think a close would have been E. So this patient has an autoimmune hemolytic anemia, and the treatment with steroids would be beneficial. Splenomegaly is also seen in patients who have spherocytes, but that's hereditary spherocytosis. So the hemolytic anemias can be broadly divided into hereditary and acquired. The hereditary disorders are either due to defects in the red cell membrane, red cell metabolism, or hemoglobin. And the acquired hemolytic anemias are either immune or non-immune. Now, the autoimmune hemolytic anemias are either warm or cold. Warm autoimmune hemolytic anemia is due to IgG, and hemolysis is due to splenic sequestration. So hemolysis is in the spleen. For cold autoimmune hemolytic anemia, hemolysis is due to complement, is complement mediated, and there's intravascular hemolysis. The peripheral smear in warm autoimmune hemolytic anemia shows spherocytes, and the peripheral smear in cold shows agglutination. So IgM, which is responsible for hemolysis in cold autoimmune hemolytic anemia, is so large that it causes it binds to more than one red cell, and there's agglutination caused. So we differentiate these also by the direct Coombs for cold being complement only. As I said before, the antibody is IgM in cold as opposed to IgG in warm. The etiologies are somewhat different, and the treatment with steroids is only effective in warm autoimmune hemolytic anemia and not in cold. So first line for warm autoimmune hemolytic anemia are steroids. And we treat it the way we treat other autoimmune disorders. So Rituxan and splenectomy can be effective in some patients. But in the meantime, supportive care with red blood cell transfusions, remembering that the cross match will never be perfect because these autoimmune antibodies cause panagglutination of all testing cells. So the blood bank will say that they cannot find blood, but you should use blood that is the closest match. The next is a 32-year-old woman who presents with 3 days of colicky abdominal pain and fatigue. Her white count is 2.9, hematocrit is 22, platelets are 60,000, and her retic count is 9. Direct and indirect Coombs are negative. Her ferritin is 10, and her abdominal ultrasound shows a portal vein thrombosis. Urinalysis is positive for hemosiderin. The most likely diagnosis is which of the following? Okay, we have more answers coming in. And yes, you're right, this patient has paroxysmal nocturnal hemoglobinuria, which is what most people answered. Paroxysmal nocturnal hemoglobinuria is due to a mutation in the PIG-A gene. So the PIG-A gene is responsible for GPI anchors on red cells, white cells, and platelets that protect the red cell from complement-mediated activation. In the absence of GPI anchors, the patients have the red cells are liable to unrestricted complement activation and hemolysis. The features include chronic hemolysis, urine hemosiderin, which causes an iron deficiency, thrombocytopenia, and thrombosis, particularly in unusual sites, so hepatic, mesenteric, and cerebral veins. The diagnosis is by flow cytometry, looking for the absence of CD55 and CD59, and this is the only diagnosis for which flow is looking for the absence of cell markers. And the treatment is eculizumab, as well as steroids, and allogeneic bone marrow transplant is the only curative therapy. So eculizumab is a monoclonal antibody against C5. It binds to C5 and prevents the cleavage of C5 into C5a and C5b, where C5b is needed for the formation of the membrane attack complex that is responsible for complement-mediated hemolysis. The next is a 34-year-old Hispanic woman who's 20 weeks pregnant. She presents with generalized aches and fatigue. She's had one episode in her life before. Her pulse is 102, temperature is 101, blood pressure is normal, she's jaundiced, and her labs show a hematocrit of 22, white count of 14, platelets of 420, an LDH of 574, and 15% reticulocytes. And this is her peripheral smear. What diagnostic test is most appropriate? Okay, yes, the answer is B, and that's what most people chose. A hemoglobin electrophoresis is the most appropriate test, and this is because not only her presentation, but also what is seen on her peripheral smear. So the arrows show, two arrows are pointing to sickle cells, which are pathognomonic for a sickle cell disease, and one of those arrows is pointing to a target cell. 8 hours later, she presents, she's short of breath, she has chest pain, she's tachycardic, diaphoretic, her room O2 sat is 83%, and her chest x-ray shows bilateral lower lobe infiltrates. What's the most appropriate next step? Let's see, so we have very few votes in for this one, but the answer is E, and we would expand antibiotic coverage for atypicals and exchange transfuse the patient immediately. So the sickle cell syndromes are due to a point mutation in the beta globin chain of hemoglobin, where instead of glutamic acid, there's a switch to valine. Now, under conditions of deoxygenation, red cells that have sickle hemoglobin in them change conformation in such a way to allow docking red cells, docking molecules of hemoglobin, that form these 14 fiber polymers that align themselves in red cells and cause the sickle shape. Sickle cell anemia refers to the homozygous inheritance of the sickle gene. The hemoglobin electrophoresis shows sickle hemoglobin making up to 75 to 95% of hemoglobin. By the time patients are adults, they have functional asplenia, and vaso-occlusive crises are the hallmark of sickle cell disease. Common complications include acute chest syndrome, aseptic necrosis of the bone, priapism, and retinopathy. And acute chest syndrome is a major cause of mortality and so needs to be identified swiftly. I'm showing this table from a randomized trial on patients who had acute chest syndrome. Acute chest syndrome is characterized by fever, chest pain, shortness of breath, hypoxia, and new infiltrates on the chest x-ray. And I show this table just to show that although to point out that although the objectives of this trial were to identify causes of acute chest syndrome, up to 45% of patients, the causes were still unknown. And of those that had infection, a significant portion were atypicals. Therefore, when we treat patients with acute chest syndrome, our antibiotic coverage has to cover atypicals. Red cell exchange is to a goal hemoglobin S percentage less than 30%, and our supportive care is aggressive. Treatment of bone pain crisis or fluid repletion and liberal pain medication only as needed. And the treatment that we've had forever to prevent or to decrease frequency of crisis has been hydroxyurea. Hydroxyurea was approved in 1998, and for the longest time there were no other medications specifically approved for sickle cell disease. But since 2017, we have really expanded the number of drugs on the market to treat patients with sickle cell disease. It now includes L-glutamine, which improves red blood cell redox balance. There's crizanlizumab, which is a P-selectin monoclonal antibody. Voxelotor increases hemoglobin oxygen binding, and allogeneic transplant and gene therapy is currently in human clinical trials, and so it's really exciting. Sickle cell trait is not a disease state. The vast majority of patients are asymptomatic. It is the heterozygous inheritance of the sickle gene, and patients have less than, or individuals have less than 50% hemoglobin S. Very rarely, however, these individuals may have renal complications or splenic infarcts. There is this poster child who played for the Pittsburgh Steelers, who was completely well, even under exercise, but during a game at a high altitude, had a splenic emergency. So in summary, we've talked about anemias. We've tried to go over a number of them, pointing out that the reticulocyte index is really key to narrowing your differential of causes of anemia. When the reticulocyte index is high, it's a hemolytic anemia or blood loss. And when the reticulocyte index is low, depending on the MCV, you can really narrow down the differential further. We talked about differentiating iron deficiency from anemia of inflammation, based mostly on the TIBC and the ferritin. Soluble transferrin receptor is normal in anemia of inflammation, and the bone marrow iron is also normal in anemia of inflammation. We talked about differentiating folate from B12 deficiency, where methylmalonic acid is increased only in B12 deficiency and not folate deficiency. And vitamin B12 deficiency also is associated with neurological deficits. Intrinsic factor antibody is specific for pernicious anemia, an autoimmune disorder that's associated with vitamin B12 deficiency. We talked about hemolytic anemias. You see spherocytes in autoimmune hemolytic anemia and hereditary spherocytosis. The diagnosis of autoimmune hemolytic anemia depends on a direct Coombs test being positive. We talked about sickle cell disease, urgent exchange, and acute chest syndrome with a target hemoglobin S of less than 30%. And we talked about PNH, where the gold standard for diagnosis is flow cytometry looking for the absence of CD55 and 59. And treatment is with a monoclonal antibody, eculizumab. These are my disclosures. And these are references, and thank you for listening.
Great job. So we have a bunch of questions. The first question is, do patients with PNH with thrombosis get anticoagulation? And if so, for how long?
So patients with PNH do get anticoagulation. Quite often, we put them on anticoagulation indefinitely. This is because a PNH usually is a chronic disorder, and we believe that their risk for thrombosis is indefinite. So yes, so our patients with PNH who get thromboses remain on anticoagulation indefinitely.
Okay. There's another question. When was the last time you diagnosed folate deficiency? Our hospital won't measure folate anymore because they say it doesn't happen.
Well, your hospital is right. So the last time we diagnosed folate deficiency, it's really was in a patient who had an eating disorder. So because so many foods in the United States specifically are fortified with folate, and really that's because of pregnant women and trying to prevent neural tube defects. There's a lot of folate in the American diet compared to diets outside the United States. And therefore, folate deficiency really is seen in only patients who have, or individuals who have some eating disorder that severely restricts their eating in a particular manner. So your hospital is close to completely correct.
If a patient is admitted through the emergency room and receives packed red cell transfusions, is there any point in doing a diagnostic workup for anemia after transfusion?
Well, first, it depends on how severe the anemia is. Certainly, it's ideal to get a diagnostic workup prior to transfusion. But once the patient has been transfused, there are some things such as the reticulocyte count, some responses that we would like to see that you can no longer detect. Having said that, if we have a patient who comes to the emergency room severely anemic and gets 1 unit of blood just to keep them stable, we do try to do a workup of what we can while they're in the hospital. For instance, it could be a GI bleed. we wouldn't send the patient out unless we would try our best to identify what we can and do the rest of the workup as an outpatient.
So you said that you don't give EPO to a hemoglobin goal of greater than 12. Is that true regardless of the starting or baseline hemoglobin?
That is true regarding that's true in all circumstances. And this is because of these are large studies in renal patients where the cardiovascular outcomes were inferior in patients who were driven to a normal hemoglobin and hematocrit of 36, 12 and 36 with erythropoietin stimulating agents. So we do think that there is a disadvantage of that high target, and we across the board do not aim for a hemoglobin greater than 11 in patients who we are giving erythropoietin stimulating agents. Besides, it's usually not covered by insurance.
Right. Okay. Does a ferritin above 200 essentially rule out iron deficiency even in the presence of inflammation?
So I would say, so as a hematologist, I would say yes. However, I know that our renal colleagues have a higher threshold for ruling out iron deficiency. Actually, I think what they're ruling out is response to intravenous iron. So we would say that if your ferritin is 200, you are not iron deficient. But there is some indication that patients will respond with ESAs, so erythropoietin stimulating agents, more avidly if you give them intravenous iron, even if they are not absolutely iron deficient.
Okay. And what are the differences in cost among the various IV iron preparations?
So the least expensive, so this varies depending on, right? So when a patient comes to get intravenous iron, it's not just the iron that a patient pays for. He used to pay for nursing and then the institution, et cetera, but the cheapest formulation is low molecular weight iron dextran. It's given at one dose, and the formulation, even outside of the number of encounters a patient has to make with the institution, is cheapest. I think the other formulations depend on the cost of the other formulations are not very far from one another, and it depends on the institution.
Okay. Do you give IV iron after blood transfusion?
If I thought the patient was iron deficient, yes, I would. I mean, there is no contraindication to giving iron after a blood transfusion. And when a patient is severely iron deficient, even after you make up the hematocrit, the hemoglobin or hematocrit with the transfusion, the patient will need iron supplementation. So yes, I would give IV iron if I thought the person was needed iron supplementation.
Okay. Are there any sources for B12 for vegans who do not want to use supplements?
So if this vegan does not take any any animal protein, a patient who not that I know of. Supplementation can also be oral or sublingual, right? It doesn't have to be IM, and sublingual is usually quite easily tolerated. So that's what I would recommend.
And what do you think is the best IV iron replacement? There are several people who say they've seen adverse reactions with Venofer.
Oh, no, I don't share that. I don't share, I have not, I can't say that I've seen more reactions with Venofer. And I think they are equivalent. Our retrospective studies showed them to be equivalent. And as far as ferraheme is given as it is now recommended, not the 15-second shot, but given over 15 minutes, I think they are equivalent and we use them as such.
Great. Okay.
Oh, I can also say that, I should also say that, so ferric carboxymaltose has been associated with hypophosphatemia in some patients. So I would check a phosphate level if you're giving that medication, especially if you're using it chronically.
Great. Okay, I think we can move on. Thank you, Maureen.
Oh, it's my pleasure. Thank you.